Welcome everyone to the new episode of the ACHD Hive. My name is Dr. Bouchard. I'm the founder of the ACHD Hive. And today I'm really pleased to welcome Professor Tutarel. He will be talking to us about ACHD patients and aging population. The first half of the session will be his presentation, and then the second half, we will have a discussion with our panelists, Professor Gatzoulis and Dr. Wichert-Schmitt. The second half will be open to all participants to ask questions. You can either raise a virtual hand or ask questions in the chat. So with no further ado, Professor Tutarel.
Thank you, Melissa. Let me share just my screen.
Oh, hi. How it works.
So can you see the screen? So Melissa, thank you for the kind invitation and also the kind introduction. It's a pleasure and honor to be here. And I think I attended it one as a panelist, so I'm happy to be called back. And so let's see. That works. Can you see it now in presentation mode? Fantastic, great. Let me just switch to a laser pointer. Great. So yeah, my topic is ACHD patients in aging population, and I don't have any conflicts of interest. And I think it's always good to look back at where we're coming from. And this is from Sir Osler, who kind of wrote that textbook for medicine. It was much easier 130 years ago in one sense, not in everything. But at that time, you just needed to read one book, and it was his book about medicine. And you could read everything which was available on knowledge there. And he even wrote a chapter on congenital heart disease. It was only a few pages, and he started it with this paragraph, which in essence says, well, you don't have to really take a look at this topic because they either die, and those who don't die, we can't do anything about it. So it's not really of interest. So that's where we are coming from. And nowadays, and this is actually even old data from Paul Carey, but it beautifully showed that age at death has changed for our patients. During the 1980s, was still a disease where was a quite mortality in the young, and only a few patients really reached adulthood and then old age. And now this is 20 years ago, and you can see that there is a shift that our patients are getting older and older, and the age of death is getting higher and higher, which is kind of a testament to the success story we had in pediatric cardiology, pediatric surgery, intensive care, and what is all included into it. And I'm sure if you look at it right now, it's even more shifted. And this is a paragraph from Helmut Baumgartner's editorial, and you can see that the number of children are more or less stable with congenital heart disease. ACHD patients are increasing, so their numbers are getting more and more. And patients over the age of 60s are also getting more and more. And this is a beautiful study which looked at the prevalence of congenital heart disease globally. And you can see on the left-hand side that the number of patients and the blue bars are the status at 1919 and the red dotted line is 2017. You can see that there's an increase of patients with congenital heart disease globally. And it is especially true for adults with congenital heart disease. And if you look at low and high income countries, you can see in high income countries, it's more or less stable. Actually, children with congenital heart disease are less frequent right now than there used to be. This might be to be better diagnosis prenatally and maybe some abortions or whatever. And you can see the only age group which is really increasing in high-income countries are those over 50 years of age. This is not the same for low-income countries, but I think this will also shift over time to this picture. And this is data from my time at the Brompton, where I was a fellow with Michael Gatzoulis, and you can see that the number of patients at the Brompton increased from 2000 to 2012, and these were patients over the age of 60 and with congenital heart disease. And we saw a ninefold increase. And this was not only true for simple defects, which is the blue line, but also for moderate and complex defects. So this is an increasing population which we are dealing with right now. And if you look at survival, you can see that patients below this age of 60 years at the Brompton at the time had worse survival outcome or regarded survival outcome compared to the general population, which is kind of this line compared to the UK general population, which is true for all ACHD cohorts from all around the world. And if you looked at the patients who were over 60 years of age, initially it looked quite good. It looked like it's the same survival like the general population. But if you look closer at it, you can see if they have systemic ventricular dysfunction, like here, with more severely impaired systemic ventricular dysfunction, or the defect is complex, then still those patients who actually reach the age of 60, which are survivors, had still a guarded prognosis compared to the general population and also compared to their peers. And we looked also at predictors, what was the cause of death. And you can see it's the congenital defect itself, so heart failure in my age function class, but it was also an acquired disease. Coronary artery disease was a predictor of mortality in this patient group. And if you look at quite modern data, this is from Sweden, and Sweden has the advantage that you get kind of a number from birth on, and then you can you can look at all the data after birth and all the medical data and the health data and social security data. So they looked at patients in a nationwide study and looked at all of them who already reached the age of 18 years. Well, these are the survivors from pediatrics. And you can still see that their survival is diminished in some of these patients groups. It's a complex congenital defect. Patients still have a diminished survival. And this is probably true for all developed countries or high-income countries. And what is the cause of death for patients? It's heart failure. It's arrhythmias, but arrhythmias are getting less and less. It's still a significant problem. It's also associated with heart failure. But if there's this data again from the Brompton, from Gerhard, and you can see that heart failure is the main cause of death, especially as our patients are getting older. And we have to realize that heart failure, the incidence is increasing in our patients. And this is true for complex patients, where we would expect it more or less, but also for less complex patients. And at a quite young age, so if you look at the age of 40, you can see that 60 to 80% of more complex patients have already heart failure. And the same is true for arrhythmias, which is kind of like you can't really distinguish between heart failure and arrhythmias, they go together. But you can see that our patients have atrial arrhythmias, and they have it quite frequently, and they have it earlier and in a higher percentage than the general population. And what is the cause for arrhythmias on our patients? I will not go into every detail of the slide. It was a slide from Paul Carey's consensus paper. You can see there are a lot of reasons why our patients develop arrhythmias, and some of them you can't change because they're already there. So like the ventricular abnormalities, scar tissue, and all these things. Medication, electrolyte disturbances are stuff we can treat, but we have to understand that all or the majority of our patients have a high risk for arrhythmias. And this is shown here in the ESC guidelines from 2020. But you can see that, of course, there's a difference between the different congenital heart defects. Some of them have more supraventricular arrhythmias, some of them have more ventricular arrhythmias. But if you look at all the diagnoses here on the left-hand side, more or less all of our patients have kind of the risk to develop arrhythmias over time, especially as they're getting older. And this is kind of from the 1990s from the United States during Bill Clinton's campaign for presidency. It's the economy stupid. So if you want to win the election, you have to look at the economy. In our case, it's not just the ACHD stupid. So it's kind of, we had for a long time just looked at congenital defect and did not look at all the other problems these patients might have. And this is data from the German National Registry, where we looked at patients were all adults. The mean age was around 35. And you can see that already those patients, quite young still, had comorbidities present. And these were extracardiac comorbidities, so it's not arterial hypertension or stuff like that. And you can see it's true for complex or moderate defects, but also for simple defects. And then we looked also at the number of comorbidities, and you can see that especially as all the patients are getting older, they acquire more and more comorbidities. And this number is higher than the general population. And what is the reason for this comorbidities? Well, if you look at the risk factors, it's age, as our patients are getting older, and more of a severe congenital heart defect. So this is the risk factors for having comorbidity. And it's more or less the same for developing multiple comorbidities. It's again the age, as our patients are getting older, and it's the complexity of our defects. And if you have unreticular hearts, then your risk is higher. And this is not just an academic problem. It's not like we have a comorbidity, so what? This is data from Kostas Dimopoulos, and where he looked at renal dysfunction in our patients, and you could see that, and these are the gray areas, that all diagnostic groups, there is some form of renal dysfunction, moderate to severe to mild, but in 50 to 60% it's present. In Alzheimer's, it's more pronounced. And so this is something he could show. And then if you looked at survival, you could see that patients who have a moderate to severely reduced renal dysfunction have a much higher mortality than the comparisons groups. So it's not just an academic problem, it's kind of a problem of survival. And if you look at something which is more acquired, it's myocardial infarction, again, data from the Swedish registry. And they looked at adults with congenital heart disease. Again, this is a nationwide study. And these are patients who already reached the age of 40 years. And they looked at the number of patients who developed a myocardial infarction compared to the general population. And the red line, these are the adults with congenital heart disease. And you can see the incidence of myocardial infarction in our patient group is much higher than in the general population. And what makes matters worse was that the outcome was also worse than in the general population. What are the risk factors for developing myocardial infarction as in ACHD patients? Well, these are the normal risk factors we all have. It's age and it's gender. Then there might be some ACHD-related risk factors like the heart defect, could be dysfunction, vascular compliance, inflammation due to surgeries as a pediatric patient. And then it's also more adult risk factors. Our patients also smoke, they got diabetes, they are obese. So it's a combination of all these factors which lead to the events of myocardial infarction. And the worst outcome is probably also related to anatomy and that patients are diagnosed lately. Because if a patient with congenital heart defect comes in your ER and has chest pain, everyone looks at the congenital heart defect, no one thinks about the coronary artery disease. And this is data from George Nucleus, also from his time as a Brompton. And you can see the risk factors for coronary artery disease. It's the same more or less like in the general population. It's age, it's to a certain age, it's male gender or male sex, it's arterial hypertension, it's hyperlipidemia. So it's things we know. So what should we do? And this is from the European Society position paper. And again, you can see that some cardiovascular risk factors are more pronounced in our patient cohort, like arterial hypertension, diabetes. Smoking is probably less in the general population. This might change with the vaping devices, everything which goes around. So we'll see what that makes and what impact that has. But in the end, what we should do is patient education, of course, and we should take risk factor control. We should look at cardiovascular risk factors and treat them and look at all these factors. So this is the ideal world. And this is the reality. This is data from Boston, where they looked at patients and calculated the risk score for cardiovascular outcome MACE, so major adverse cardiovascular events, which is kind of coronary heart disease, myocardial infarction, stroke, stuff like that. So it's not congenital heart disease related. And you can see that depending on the type of congenital heart defect, so the score was even higher than in the comparison group from the hospital, but it was not zero. It was not non-negligible. So there is a risk. And then they looked at patients who were eligible to get a statin prescription and how many of the patients received a statin prescription. And again, this is Harvard, so it's not like in district. So no offense to District General Hospital, but it's not like you feel like this is a hospital where they didn't know what they were doing. This is Harvard. And as they saw that only 42% with eligibility for statin prescription ACHD patients actually received one. compared to 60% of the non-congenital disease patients, which is also not good. But our patients are worse. And then they looked at how many of our patients received a lipid panel who should receive one according to guidelines. And they saw that, well, 2/3 of the ACHD patients didn't even have a lipid panel. So it's kind of an undertreated area. And it's not just in the United States. This is, again, data from the German registry. We've looked at patients with ACHD who already had coronary artery disease, so who had a bypass surgery, who had a myocardial infarction, who had a stent, whatever. So it was established coronary artery disease. And you saw that regarding antithrombotic treatment, 80% of them received some form of antithrombotic treatment, so 20% did not receive anything, which is not good. And then we looked at lipid-lowering therapy and saw that not even 20% of our patients had a statin or anything like that. So this is kind of a real problem. So we treat the congenital heart defect, then the patients have a myocardial infarction, and we don't treat the myocardial infarction properly. A further problem in our patient group as they're getting older is non-cardiac surgeries they have. This is data where they looked at the proportion of admissions of ACHD patients for non-cardiac surgeries. You can see there's an increase over time. And if you look at the outcome, and this is again a nationwide study, you can see that the ACHD cohort with comparison cohort, which are also patients who received surgery, so this is not a healthy cohort. You can look at everything you want to. It's always worse in our patients. So more deaths, more pneumonia, more respiratory failure, more strokes. And this is not only for complicated surgery, it's also for hip replacement, for example. You have a higher rate of 30-day readmission, higher rate of complications. And if the surgery gets more complicated, you have also more complications in our cohort. And the risk to die, to have any complications or be readmitted was always higher for the ACHD patients. And then it's something we have always to talk about, and it's really a big topic right now in Germany. It's cost of medical care. And this is also something we already looked at the paper when I was at the Brompton. And we could see that our patients have higher number of hospitalizations, higher number of outpatient visits if they're over the age of 60 years of age. They had a lower number of surgery, which makes sense because they already had surgery, and nowadays you can solve many problems with interventions. But this is kind of a more intense utilization of healthcare resources. And this is, again, data from hospital admissions of ACHD patients in the United States, and you can see that the number of admissions is increasing over time. And this is true for simple defects, which are the black bars, for moderate defects, which are the green bars, and also complex defects, which are the blue bars. So there's an increase of hospital admissions. And if you look at the number of patients who are over the age of 60, you see there's a drastic increase of these patients who are admitted to the hospital. And if you look at the mean age of patients, which is this black dotted line, the mean age of patients who are admitted to hospital with ACHD is also increasing. So our patients are getting older, but they are still ill. These are not the healthy survivors. And then they looked at resource utilization, and you can see these are simple defects, these are complex defects. In the end, the cost of hospitalization is increasing in these patients, and the length of hospital stay is also increasing. So it's also a substantial problem for our healthcare system. And if you look at hospitalization costs for heart failure admissions, again, heart failure in non-ACHD patients is also not a simple disease or problematic disease, but you can still see the cost of our patients is higher. So I think we have to think about prevention because prevention is the key to help our patients, which is the most important part of it. But if you live in a healthcare system, we have to look at costs. It's also important to omit hospitalizations, to omit complications. And then there's this concept of chronological versus biological age, which means chronological age is that what is written in your passport and your ID card. So if you're born in 1950, then you are now 76 years of age. So this is a chronological age. Biological age is something different. And we all have experienced that. We have patients who are 70 years of age, and you look at them, you feel like they're 50 years of age. And then you have other patients you see and feel like they look like an 80-year-old person, but they're only 40 years of age. And what is important for these biological age are several things. It's genetic and epigenetic factors. It's lifestyle factors, kind of unhealthy diet, low physical activity. It's environmental influences such air pollution, and this is something which we realize more and more also in general cardiology. This is a real problem. And then also disease and treatments, which can also be a stress factor. And stress does something to persons, to people. And this is an example which I always like to show. This is Barack Obama before his first presidency. In 2008, he looks young and happy and very energetic. This is after 4 years of presidency before his second term. Still looking quite young and fit. And this is at the end of his second term. So you can really see this guy has aged in these 8 years of time. And he's a quite healthy person. He exercises a lot. But you still can see what happens if the environment is stressful, which is probably the case if you're president of the United States. And also lifestyle matters. So this is Russell Crowe and Brad Pitt. They're both at the same age. And this is at the beginning of 2000s. And they all both look healthy and young and fit. And this is current photographs of both of them. So Russell Crowe and Brad Pitt age differently. So it might have to do something with, I don't know, cosmetic surgery or whatever. But if you look at the figure and you can see that Brad Pitt probably aged better. And then there's this concept of accelerated aging. So lifestyle matters, and that's why I showed you these examples. And then you can also look at in more detail on cellular level and even on epigenetic level. And this is just a current study published online in the European Heart Journal. And you can see that they compared adults with congenital heart disease, simple defects, moderate and complex defects, 40 of them in each cohort, and compared them with healthy controls. And then they used different epigenetic clocks, which are kind of laboratory tests. They can look at methylation and can see how old the cell and then kind of the person is. And you can see that if you compare these different age acceleration cohorts, you can see that patients with moderate and complex defects have a more accelerated aging compared to simple and healthy controls on simple congenital defects. So these patients are already older than they should be at their chronological age. And what are the predisposing factors for accelerated age in ACHD? Well, it's the anatomy, it's the genetics, something we probably can't change, genetics. But it's also surgery interventions, the stress which comes with the surgery interventions, the environment. There are residual lesions, there's systemic inflammation. We have ionizing radiation, we do CT scans, we do chest X-rays. Metabolic syndrome can be a problem, so it's important to keep our patients active. Then there are non-cardiac complications like lung disease, kidney dysfunction. They have cardiac complications, which also are burden. And they all have an impact of these patients, and they lead to frailty, to sarcopenia, and to cognitive dysfunction. And this is something with Philip Moonshot and with this group, that our patients, and this was also quite a young cohort, are still already frail or pre-frail and have cognitive dysfunction. And it's associated with the complexity in pathological stage, with catheter interventions, comorbidities. But this is a problem. Our patients are older than they should be, and they are aging faster. So where should we look at research directions, aging, ACHD? I think it's the biology of aging, and that's, again, a graph from Philip Moons. I think it's important to realize inflammatory diseases, and this might be a problem. Epigenetic clocks, I showed you just a study. And what the impact of this aging is, it's not just an academic problem. And then you can see that interventions might delay aging in ACHD, so maybe have to use less radiation. I think we are getting better. Also, the CT scanners are getting better, and maybe should be more restricted in what we are doing. We should encourage our patients to be active, to look at their nutrition. Anti-aging drugs, I don't know, maybe we were getting there, that we have stuff like that. People are working on longevity drugs and stuff like that. And we should have supportive strategies in place, and we should realize that there is a proportion of our patients who will need supportive strategies earlier than the general population. So my take-home message is, and I like to pronounce it a lot and everywhere I go, our patients are getting older. This is not a pediatric disease anymore. And they have a lot of other problems, which the general population also has. So they have arterial hypertension, they have coronary artery disease. You have to treat it. Because these are key for the outcome. And I think prevention is of utmost importance and starts very early on. We have to start early on and telling our patients to be active, to be careful what they're eating, to stop smoking if that's a problem. And this doesn't start with 40 or 50 years of age when it's already established, but this during transition phase probably. We have to realize that there are also non-legible associated costs as our patients are getting older. It is a success story, so don't get me wrong. But we have to realize that this will be a burden on our healthcare system. We have to advocate for our patients. And I think the most essential part of it is teamwork. If you look at all the comorbidities, all the problems our patients have, it's not something that a single person or a single unit can solve. It's always working together with other units, other departments, other healthcare providers. Thank you very much.
Thank you very much, Oktay. That was a brilliant presentation. Lots of thought-provoking messages, actually. I'd like to open the floor. I'd like to welcome Dr. Wichert-Schmitt.
Hi, hello.
Welcome.
Had some technical issues first, so thank you.
It's a world of Zoom. And Professor Gatzoulis. Have you guys got any comments or questions, opinions?
Well, thank you very much, Oktay, for summarizing this very important topic. I think you brought up many issues we have to look for. One is prevention, starting early when we look after these patients, and also then in the long term, just really to figure out who patient needs what, and also probably doing a more precise risk assessment prior to any non-cardiac surgery or also to cardiac surgery. So I think it's a lot of things we have to think of and we have to do in our daily practice. So thank you very much.
Thank you. I totally agree. I think it started with thinking about it and thinking that this is also a problem. I think we were a long time focused just on the congenital heart defect and didn't look at the rest. And I think we realized more and more that this is a problem.
Do you have an explanation as to why do you think there was such a huge proportion of these patients who were in hospital in Harvard that didn't receive those statins?
We did. I think the problem in Germany is just kind of so I have to be very careful because it's a very political issue here. Because in Germany, ACHD patients are the majority treated not by adult cardiologists. And if you're not used to treat coronary artery disease, myocardial infarction, it's kind of if you went through cardiology training, it's kind of engraved in your brain, isn't it? So it's kind of coronary artery, aspirin, statin, whatever. So it's kind of like heart failure. So it's during my cardiology training we were always told if the head of department wakes you up at 2 o'clock in the morning, the first thing you have to say is like ACE inhibitor, beta blocker, spironolactone. So it's kind of like engraved in your mind. So this is just speculation. This might be the one reason. The other one might be that you kind of don't realize this might be a major problem and they're undertreated. That was our impression and that's how we discussed it. We can't prove it, to be honest, but I think it has a lot to do with awareness.
Because that may intercept here. Sorry, Melissa, just on this important point. I think it's speculative, but I think the focus has been, and rightly so over the years, on kind of the anatomy, operations, physiology, and other aspects which are clearly important, not only in the lifespan, but also quality of life of these patients have been ignored in the past. lifestyle choices. And obviously now we talk about them, but again, we don't talk early enough. And then non-congenital aspects of care of these patients have been kind of overlooked. And I don't think that applies only to pediatric cardiology practice. I think applies also to adult congenital heart disease practice, which is what we do. So I think Oktay's presentation very timely. And in many ways, what Oktay is discussing with us is the challenge of longer lifespans in general, not just the congenital population, and what comes with it. And what is the ideal outcome of this? Do we want all of us to make it 100? If we are up and about and in good health, yes, I think that's a fantastic outcome. But if we are sort of limited, bedbound, and dependent on others, probably not a very good outcome. The difference with our patients is that now, I think, is A, that we know of the diagnosis of congenital heart disease now from fetal life in many patients. So there's no excuse in that respect. B, we have more information today than 2014 when Oktay published his work in the European Heart Journal with us about the trajectory of congenital heart disease, about the trajectory of individual lesions. So I think, you know, we talk about prevention, which is always better than treating. I think we need to start prevention from the time of diagnosis, and that we need to get it. We can't do it as adult congenital heart cardiologists. We need to sort of obviously work together with pediatric colleagues and fetal cardiology colleagues. And I think the message that we need to convey to the couple at the time of diagnosis is that is in Germany or the United Kingdom, in many parts of the world, there is good infrastructure to support the sort of lifelong journey of the patients. It's a lifelong disease. And that even in moderate to complex lesions, you know, there are good prospects. Obviously, somebody with a single ventricle physiology would not live 100 years. But if they are sort of properly supported and they make the decision to continue, then one can have a very rich life living 40 years, but, you know, having a family earlier, and come back to this again and again because it's so relevant, taking best care of themselves, as we must do, that is slim and athletic. Somehow in all this, at the time of diagnosis, the couple and the young patient need to know that smoking is bad for you, that exercise is the best investment that you can make, that eating healthy, making time to cook, best diet, optimal weight, pays dividends in all of us, and more so in patients who obviously have the disadvantage. They have congenital heart disease, multiple operations, and the rest of it. So, sorry, this is a very long interception, but that's really how I see this challenge to our patients, but also to ourselves, that we need to be aware of this. They need to know of their condition, need to know about the trajectory, and they need to know what they can do to have the best sort of experience, the best, you know, the richer life possible, and also to know about complications that potentially can compromise this. You know, have this recurrent theme, and again, I think, Oktay, you published with us on the endocarditis. Our patients are sitting dark straight, and you have guidelines talking about taking antibiotics or not, which I don't know, probably makes a small difference, but they need to know, again, that to prevent endocarditis, they need to eat the best, not to smoke, they need to look after the skin. And they also need to know that they may have it and guide the local people what to do, what not to do. It's a no-brainer. So I think we and our pediatric cardiology colleagues have an obligation now, in the light of this knowledge that we have, to share this information with the couple and the patient. So then those with, I guess, moderate, mild disease that make to older age, not only survive to it, but have, good quality and the best possible outcome. So I think that's where the investment, more investment needs to be made. And we need somehow to be working together, not against pediatric and fetal cardiology colleagues to achieve that. And other disciplines, of course. But great talk, and I think very, very timely, this, not just for the patients, for all of us. Thank you.
Thank you. I totally agree with you, Michael. And I think one thing we have to do is kind of shift our mindset, and also the mindset of our patients, especially adult ones. For example, regarding exercise, we had a lot of patients who were told you shouldn't exercise, you should be calm, it's very risky, don't do anything. And then we kind of to encourage them to exercise and to work and to be active as possible, as much as possible. So you don't have to run a marathon or be a bodybuilder, but you can be active and be physically active and try to climb stairs and stuff like that. I think this mindset shift, and the same as endocarditis. We published together the data from the Bront, and then we also looked at data from German registry, and we asked patients, do you think you're high risk for endocarditis? And do you need endocarditis prophylaxis? And it was astonishing that many patients who were not high risk thought they were high risk. And patients who were really, really high risk with mechanical warp, stuff like that, felt like, no, I'm not high risk, I don't need anything. It's not about just endocarditis prophylaxis, but everything else. So which shows that we all have to get better in educating our patients and our colleagues and not only just getting the message also across. It's not just telling someone something. I think this is something we know from the whole of general from medicine. It's also in cancer. Telling people something it's like this. It's not like it's engraved in their brain. So they go out of the room and they probably lost I don't know how many % of the message already.
I think it's also a kind of positive information you can give your patients. You can tell them if you do exercise, if you have a healthy diet, if you're not obese, if you don't smoke, you can actually contribute actively to remaining well for a long time. So I think it's quite a positive thing to tell them and to motivate them, but you have to do it again and again. When they come to your clinic, yes, of course.
Yeah, totally. You have to empower them. I think it's very important for them to have the feeling like if you look at parents with congenital defect children, you feel like they want to have control over something. So they give away their baby to the surgeon, whatever, and they want to have the feeling of, I can control something. It might be the feeding, it might be the medication, whatever. Mm-hmm. And I think it's the same if you give the adult patients a feeling, yeah, you're in control, you have the power to kind of change the trajectory of what you're doing, and not everything, but you have a very big positive impact. I think it's totally agree with you, Barbara. It's kind of, yeah, very important.
And we need to do it ourselves. The best way to influence somebody else in your immediate environment is to do it yourself. That's the only way that we can make progress. So we need to make time for cooking, and we need to make time for exercise. So then we can influence a few people in our immediate environment and the patients themselves. So I think, yes, there is opportunity here. I guess in Berlin, you are sort of, with pediatric cardiology, you're under a single roof, Oktay, so then this kind of essential communication takes place, is it, with a pediatric and fetal cardiologist?
Yeah, we have this group of congenital heart disease, so it's one big department, but the ACHD center is kind of standing for itself in the pediatric cardiology, but we have a very, 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 very close collaboration and share patients and boards and CTI, MRI and everything. So it's easy to communicate and to kind of learn from each other, and I think this is always very helpful.
And you have a patient association to help with that, campaign?
Absolutely, we have, and we have also the German Heart Association, which is getting more and more active in this field, and so it's kind of a foundation for patients, and there's stuff going on and more education. We're probably too late, as everywhere, but now people realize more and more the importance of these things. So we're working on it.
We'd be interested to hear from elderly patients their view of this. it would be interesting just to sample from different places, different countries, maybe, Oktay, a little survey, but it would be quite helpful. And I'm very happy to, work with colleagues just to capture, let's say, 100 patients with different conditions making their 70s and have their perspective to this.
Absolutely.
It won't be very scientific, but it'll be very interesting to hear from them what they think in the process. And, anecdotally, I can say that patients obviously have been traumatized in the first instance with the diagnosis, and then kind of having multiple interventions, managed to live with uncertainty, and some with physical disability. In my experience, the majority, not all, the majority have coped well with it. And in some ways, it's a philosophical bubble, I guess. Adversity is part of life, and our patients have plenty of it. And still, they're fully aware of the prospects, which obviously have improved because of the infrastructure of what we've been doing and so on. But it would be, I think, great to have their view, their perspective, particularly the elderly patients. Yeah, just a thought.
Very interesting. So I think it's just kind of totally agree. They had a lot of trauma, and then also they're very, very resilient, at least those who are over the age of 67 years of age. It would be very interesting to see it, so to kind of analyze it more in an analytical way, and could be very interesting. Yeah.
We have a question or two questions in the chat. One is from Magali. Oktay, are there any interventional trials that have demonstrated an effect on biological age in patients without ACHD? And when should we start evaluating frailty in ACHD patients? Should this evaluation take place at an earlier stage for complex congenital heart disease?
Oh, thank you, Magali. Great to have you here, and thank you for the difficult questions. I think there are some trials out there. I'm not a longevity expert, but there are trials out there where they show that they looked at telomere length and stuff like that. And it's mostly what Michael said. It's exercise, it's healthy food, it's a Mediterranean diet, as we call it here in Germany. It's kind of eating healthy. And it does have an impact on also biological aging. And even if you look at frail patients, you can kind of reverse frailty for a certain amount of this frailty. So it's kind of, there are studies also which show that mostly it's healthy living, exercise, stuff like that. I'm not aware of any medications. Probably if you use, I don't know, heart failure and statins, I'm not sure if they ever looked at the accelerated aging, to look that up, to be honest. And when should we start looking at frailty? Probably much earlier, as you said, especially in complex patients, but also in simple patients. I don't have an age cutoff because all the research has just started, but from a group from a transplant program just looks at this topic. And even assessing frailty is not easy because there are so many different measurements of frailty out there. None of them is really established, especially for a patient group. But we have to probably look much earlier at this cause and realize that this might be also an effect on our patients. And it's kind of like, if patients have problems standing up from the chair, there's some very simple tests where you kind of, how long do they need to stand up and how they walk. It's not always the congenital heart defect, and because they're limited by I don't know, shortness of breath or whatever, might be also frailty. So it might be worse to look before, but I can't give an age cutoff, to be honest. Probably earlier than in the general population.
Vanda has asked a question. Hi, Hannah. What tools do we use to stratify patients with ACHD? Do we apply the same as the general population, so score 2, or do we automatically classify them in a high risk, thereby lowering their threshold to start treatment, for example, with statins? What's everyone's practice?
Yeah, so it's kind of good to have you also on board and on this meeting. And so if you look at risk scores, there's currently a discussion going on in general cardiology about all these risk scores because there are plenty of them. So the European, American, whatever, every society has a risk score. And then they looked at if does it really add something to age and gender? And probably it does not add a lot to it. So it's a general population. It's not about ACHD, it's general population. So there's an academic discussion going on. If you go to X, I'm not a very active user of X, but if you go to X and then you see the discussion, it's very interesting to see. And if you look at the Kaplan-Meier curves and the ROC curves, they kind of really look close to each other. So maybe it's, I can't say use this risk score, this one. We don't use risk scores right now to assess our patients, to be honest. But we look at the patient, we look at stuff like cholesterol, so high LDL, and treat hypertension. We try to treat them and to make sure that they kind of reach reasonable levels and don't have arterial hypertension and stuff like that. But I think there's not really an established risk score for our patient group and cohort, especially considering the wide variety of our patients. And as the scores are even problematic as a just normal general population with coronary artery disease.
Yeah, I think the ESC guidelines in prevention actually do not mention the ACHD population at all.
No, but I think it's
change this, huh? Sorry, I keep interrupting everybody. Sorry, Barbara.
No, I just wanted to add, I mean, all these risk scores are mainly helpful for starting lipid-lowering therapy, isn't it? Because just trying to not be obese and not to smoke and treat hypertension, you would not go for this risk score. So if you look at all these other factors contributing to atherosclerotic disease, because that's what you want to prevent. All prevention scores are only to prevent coronary artery disease and stroke. It does not prevent HFpEF and then all these other cardiac diseases which you can acquire when you get older. But I think if you treat hypertension, if you treat obesity, if you motivate them to be active, if you also already do a lot, and then at some point you decide on lipid lowering therapy as well. But it's not only that.
Maybe would like to say hello, Melissa. Sorry, who is our consultant nurse and lead of the services. She's doing her PhD looking at the patient perspective, particularly in the heart failure group, developing a lot of useful tools. Yeah.
Nice to meet you, everybody. Hello.
Yeah, very good to see you.
Nice to meet you. Hi.
Thank you. Thank you very much.
I was just going to ask everyone's practice actually, because I know that at the Brompton, every time we saw a patient, everyone had a BMI. We used to do blood pressures and everyone had an ECG. We did do quite a lot of tests ourselves for every patient in clinic, which kind of falls on the looking for any risk factors. But I'm not sure that I don't seem to recall that we did statins or lipid profiles. So I just wondered if things had changed or if people did. How often would you do and when do you start?
I think we do it for any patient for cardiac surgery coming. We do a baseline lipid profile, but I don't think we do it for everybody.
We should.
Which I think we should change the practice.
Sure.
Yeah.
Sure.
Because now they're living longer and reaching the stage of kind of coming to adulthood and living longer. So maybe that's something we need to kind of collectively, colleagues internationally to do that. Yeah.
And I think that also has changed over time. So, I mean, we used to have age cutoffs in general cardiology when you should do it. They say everyone should measure his lipoprotein A alpha at least once. So just to make sure where your risk is and if you have high risk. And then, again, if you have an obese patient at 30 years of age, you probably should do a lipid profile in these patients. If they are, I don't know if you... So it's kind of, I would have a very low threshold to recommend to do a lipid profile and also HbA1c, so just to make sure that they don't have diabetes and stuff like that. I think it's very important. I think the threshold is getting lower and lower, and also in general cardiology, it's not, because it's also counted biological age and then the chronological age. It's not like you have very fit persons who are not 30 years of age, and then you have persons who are 30 years of age and who look like, I don't know, like the grandfather to be kind of very.
What do you recommend, Oktay? Obviously, in UK, all patients over the age of 45, they have 3 yearly checkup with HbA1c, lipid profile, etc. But considering our congenital heart disease patient population from chronological age are different, what is your practice? What do you think would be the recommended age to start with?
Question.
It depends on, it's a very good question, thank you. It really depends on kind of also the congenital defect. So a patient with coarctation of the aorta, I always recommend to have a lipid profile because they have a higher risk for coronary heart disease, and they always have 24 blood pressure management, even if they're 18 years of age. So this is what we always recommend. Then in Germany, we have kind of this check-up for the general population when they're 35 years of age, where you can get measurements, stuff like that. It's really, it's if you go to the doctor and get it, I mean, it's like with everything, like colonoscopies and whatever. And then, but as I said, I have a quite low threshold. I don't know, TJA patients who had kind of an HV switch and stuff like that.
Yeah.
So it's kind of, if I feel the patient's obese, not very active, it's a very rough measurement. It's kind of like, it's not really evidence-based. But I have a low threshold in a patient with a cardiac disease, and congenital heart disease is a cardiac disease, to tell them, get at least one check of the lipids. And if the lipids are fine and you don't know, have an LDL of 90 and everything is good, you don't have any problem, you don't have to do it the next 5 years, whatever. But generally, I recommend them always to kind of have some form of checks of these lab values. We also
Very
check for iron
individualized.
deficiency in every patient, to be honest.
Yeah.
We always recommend iron deficiency to check for it, even if they don't have any symptoms or feel like that, because it's also very common. So it's kind of like, yeah.
Thank you.
It should be like a panel, isn't it? Like a panel of blood tests that as soon as you're transitioning into the adult clinics, because then you can see if there's a progression or not. Like, okay, your cholesterol is this now, but it was that 2 years ago. There's obviously some disease going on. And Barbara, what's your practice?
Well, luckily, we do not have any restrictions, financial restrictions, so I can add it every year to all the patients. Actually, what I do also for the HbA1c, and actually I already did see, without having any real explanation, then this is quite, even in younger ACHD patients who have no other risk factors for acquired heart disease, that is actually elevated. And I even had to have the impression that it might be higher in those who are going into heart failure and who are in a worse condition. I have no explanation for that, but it is an issue, definitely, and I just can add it to every visit blood panel I do. Yes.
And what about this lipoprotein A? Have you already started testing patients for that?
Yeah, you do it once. Yes, you do it once,
Yeah,
and I think it doesn't change very much. So you can do it when they come to your clinic, actually. Yes.
Because I suppose if it was very high, then it would then trigger you to think, okay, well, we can't yet treat this lipoprotein A, but we should really be looking at all the other risk factors. I suppose then you become a bit more cautious about, a bit more aware to make sure that the risk factors are low. But I mean, it wasn't around when I was at the Brompton, but everyone's talking about it now. So, Oktay, do we do it in Germany?
Well, we recommend. The problem is we're not in the same position like Austria, where everything is get paid.
Yeah. Nobody questions it at the moment. It might be different soon.
we are not allowed. So we are allowed to. I mean, you can do whatever you want in the clinic, but you're not getting reimbursed for that. So we started doing it in every patient we have to shut down Charité probably, and so we have to recommend it for the GP to do it, and so we can do blood work, but not just in special patients, and then we check it. But otherwise, we always recommend it for the GP. Germany is a GP-based healthcare system, and it's getting more and more like that. So we are not getting any reimbursement for doing any lab tests. So but we recommend it.
I wonder, Prof, is that the case for the NHS? Lipoprotein A, are we doing that?
Yeah, there are no restrictions. I think we just need to get our act together.
And prescribe it.
We need to be proactive. No, the framework, NHS too big, too bureaucratic, but the framework is there to support activity. and most of our research was based on NHS resources. So we can do much better than this. Somehow tunnel vision, the distraction is no end to it. The bureaucracy is killing us. I don't think it's just the UK in general. Just need tunnel, best care to the patient and the learning from it. A lot that we can do more. And what I was saying earlier on about communication education is, costs nothing. You just need to do it. And clearly the interaction with the patient has changed. We're not telling the patients what to do. We share with the patients the information so they make choices. And the patients are smarter than us. But it's just this communication and going back to it and so on. The patients should know more about me on their condition. It's a no-brainer. Am I doing this? No. So there's a lot to do, Melissa and colleagues. So we need to stay restless. We're making progress. And as Oktay presented, we are the victims of our success. But, it's a good story. There's more to do for us. Yeah. Great form, Melissa. Really appreciate it.
Thank you so much. Well, we'll conclude there. It was a lovely session. I think we'll all agree that if the guidelines were a little bit more targeted for our patients, it seems that we wouldn't have to do so much guesswork. So that would be something to improve, such as suggested communication with patients, education of patients, but also education to us, the new generation of doctors, the general cardiologists as well, who've got so much now involvement in some of our patients. But thank you very much, everyone, for attending today. And I will stop the recording now, and it will be on the website later on.